You know that burning sensation, that nagging discomfort after a meal? Maybe even a sour taste suddenly rising in your throat.
Mhm.
Most of us just shrug and call it heartburn, and yeah, it feels incredibly common. But what if I told you that very sensation is often a sign of something far more chronic and complex? A digestive disorder known as GERD. Okay, let's unpack this. Today, we're taking a deep dive into gastroesophageal reflux disease, GERD. We're going like way beyond just the surface discomfort to truly understand what it is, how it takes hold,
Yeah.
what it really feels like, and why understanding it deeply matters for your health and, well, your overall well-being.
Absolutely. Gastroesophageal reflux disease, or
Yeah.
GERD, at its core, it's a chronic digestive disorder. Basically, stomach acid or sometimes even bile flows back. It refluxes into the esophagus. And this backward flow, it's not just a fleeting thing. It causes persistent irritation and some pretty uncomfortable symptoms. The fundamental reason this happens is typically because of a weakening or dysfunction of the lower esophageal sphincter. We just call it the LES
Yeah.
mostly.
The LES.
Got it. So our mission in this deep dive is to give you a real shortcut to being truly well-informed about GERD. We're going to explore its maybe surprising origins, those unexpected ways it can show up, the diagnostic tools that finally connect the dots, and the whole array of treatments available. Hopefully you'll have some genuine aha moments.
Okay, so to really grasp GRA, we have to start with that crucial component you just mentioned,
Right.
the LES. Let's picture it. It's like a clever muscular valve at the very bottom of your esophagus, right, where it meets your stomach.
Exactly.
Its entire job is just to open up, let food slide down, and then bam, snap shut tightly to prevent anything from the stomach, especially that strong acid, from splashing back up.
Precisely. And in GERD, that finely tuned valve, it's just, well, it isn't working quite right. Instead of keeping that tight seal, the LES either relaxes when it shouldn't, allowing stuff to surge back, or maybe it's just chronically weak. This basically opens the door for stomach contents, which includes, corrosive acid and digestive enzymes, to reflux back into the delicate, sort of unprotected lining of the esophagus.
That's fascinating. So it's not just about a weak valve, but what else is going on? What other kind of mechanisms do we need to understand about GERD's origins beyond just the LES? Because you said it's complex.
You're right, yeah. While LES dysfunction is central, several other things play a pretty significant role. For instance, a common contributor is something called a hiatal hernia.
Okay, heard that.
This is where a part of the stomach actually pushes up into the chest cavity through a little opening in the diaphragm. And that can directly mess with the LES's function, making it harder to seal properly.
Makes sense.
Then there's delayed gastric emptying. Digestion just slows down. So if food and acid hang around in the stomach too long, it increases pressure.
Right, pushes things up.
Exactly. Makes reflux more likely. We also look at esophageal clearance mechanism impairment. Sounds technical, I know.
Yeah, a bit.
But it basically means maybe reduced saliva production. Saliva helps neutralize acid, you see. Or impaired peristalsis.
Peristalsis, those muscle waves?
Yep, the wave-like muscle contractions that normally push food down. If those aren't working efficiently, acid just kind of lingers in the esophagus longer than it should.
Gotcha.
And finally, increased intra-abdominal pressure can be a big one. Think about it. Obesity, pregnancy, even wearing really tight clothing or straining, all these things can ramp up the pressure inside your abdomen, physically pushing stomach contents upward.
Okay, so if we put all these pieces together, who's more likely to end up dealing with this? Like, is there a typical profile or lifestyle?
That's a great question. When we look at risk factors, several lifestyle things stand out. Obesity is a big one. It significantly increases risk. Same with smoking, heavy alcohol use, even regular caffeine intake for some people.
Coffee. Oh, dear.
Yeah. And diet definitely plays a role. Fatty or spicy foods, large meals, eating late at night. These can all contribute. Beyond lifestyle, certain medical conditions raise the risk, like that hiatal hernia we talked about, diabetes, pregnancy, mainly due to hormonal shifts and increased pressure. And maybe surprisingly, some medications can play a part too. Things like calcium channel blockers for blood pressure, or even common pain relievers, NSAIDs.
Right. Okay, so let's talk symptoms. When most people think GERD, like I said, it's heartburn, right? That classic burning. And that's definitely a major player.
Absolutely. Heartburn, or pyrosis as we call it, is the hallmark symptom. It's that classic burning feeling deep in the chest, right behind the breastbone, often gets worse after meals or when you lie down. Then there's regurgitation. It's exactly what it sounds like, that unpleasant experience of sour or bitter liquid, could be acid or bits of food, rising up into your throat or mouth.
Ugh. Yeah.
And for some people, they might experience dysphagia, which is difficulty swallowing. That can happen if the esophagus gets inflamed or even narrowed over time from the acid.
But here's where it gets really interesting, I think. GERD doesn't just cause those classic symptoms. It can, disguise itself, right? Show up in ways you never expect, like battling a chronic cough for ages and finding out it's actually reflux.
Absolutely. We call these atypical or extraesophageal symptoms, precisely because they happen outside the esophagus. We often see respiratory symptoms like that chronic nagging cough you mentioned, or it can make existing asthma worse, sometimes even recurrent pneumonia, believe it or not, from tiny amounts of acid getting into the lungs.
Wow.
And in terms of ENT symptoms, ear, nose, and throat GERD can cause laryngitis, persistent hoarseness, that weird feeling of a lump in your throat, globus sensation.
Oh, yeah, I've heard of that.
Chronic sore throat, and even dental erosions. Constant acid exposure can literally wear away tooth enamel. So yeah, these things that seem totally unrelated can be directly linked back to reflux.
Okay, so with all these different symptoms, some obvious, some really not, how do we know when it's just, annoying versus something we really need to get checked out? What are the red flags, the alarm bells?
That's a critical point. These are what we call alarm symptoms, and they really do demand prompt medical evaluation. They include progressive difficulty swallowing, meaning dysphagia that gets steadily worse, or painful swallowing, which we call odynophagia.
Okay.
Unintentional weight loss, losing weight without trying. That's a big red flag. And crucially, any signs of internal bleeding, vomiting blood, which is hematemesis, or having black tarry stools called melena, that indicates bleeding somewhere in the digestive tract.
Definitely serious signs.
Very. And lastly, anemia, low blood count, which could be from chronic, slow blood loss, even if you don't see obvious bleeding. These signs should never, ever be ignored. Seriously, see a doctor.
Okay, absolutely. So given how uncomfortable GERD can be, even without those alarm symptoms, people must wonder, what happens if I just live with it, if it's left untreated? This is where potential complications come in, and yeah, some sound quite serious.
Unfortunately, yes. If it's left unmanaged, that chronic irritation from reflux can lead to significant problems. The most immediate is esophagitis, basically inflammation and erosion of the esophageal lining. Think of it like a constant chemical burn on that sensitive tissue.
Ouch.
Yeah. Over time, this chronic inflammation can lead to esophageal strictures. These are narrowings of the esophagus because scar tissue builds up, makes swallowing increasingly difficult, sometimes painful.
Okay.
Then there's a particularly significant complication, Barrett's esophagus. What's kind of fascinating in a medical sense is your body tries to protect itself from the acid by actually changing the cells lining your esophagus.
Changing them? How?
It's a process called metaplasia. The normal lining transforms into a different type of cell, more like the cells found in your intestine, which are tougher against acid.
Huh.
But unfortunately, this change, this Barrett's tissue, carries a small but definite risk of becoming cancerous over time. Specifically, esophageal adenocarcinoma, which is a serious type of cancer.
Wow, okay. That's a major reason to get GERD managed.
Absolutely. Yeah. And don't forget those respiratory complications we touched on. Aspiration pneumonia, chronic bronchitis, worsened asthma, all from acid irritating the airways repeatedly.
Right. So if you're having these symptoms, maybe even suspecting GERD, how do doctors actually pin it down? It's not just a guess based on heartburn, is it?
No, you're right. It's usually a structured process. Often it starts with a clinical diagnosis, just based on those typical symptoms like heartburn and regurgitation, especially if they're frequent.
Okay.
A very common next step is what's called an empirical PPI trial. You're given a course of proton pump inhibitors, those strong acid-reducing meds. If your symptoms improve significantly, that strongly suggests GERD.
Makes sense. Like a therapeutic trial.
Exactly. But for a more definitive diagnosis, especially if there are alarm symptoms or the PPI trial doesn't work well, or maybe before considering surgery, diagnostic tests are used.
Like what kind of tests?
Well, the upper endoscopy, or EGD, is really considered the gold standard for looking directly at the esophagus lining.
So a camera down the throat.
Yep. It lets the doctor see any inflammation, erosions, which we actually grade using something called the Los Angeles classification, or ulcers, strictures, and crucially, check for Barrett's esophagus. They can take biopsies too.
Okay. What else?
Another key test is 24-hour pH monitoring. This actually measures how much acid is refluxing into your esophagus over a full day. There's a little probe placed, or sometimes a wireless capsule clipped inside, called Bravo pH monitoring. If your esophageal pH drops below 4 for more than 4% of the time, That's diagnostic for GERD.
Wow, that's quite specific.
It is. We also sometimes use esophageal manometry. This measures the pressure of the LES as it went and also checks the muscle contractions, the peristalsis in the esophagus.
See how well things are moving.
Exactly. And a barium swallow or esophagram is an X-ray test where you drink a contrast liquid. It's good for spotting things like a hiatal hernia or significant strictures. There used to be a Bernstein test, an acid perfusion test, but it's rarely done nowadays.
Okay, quite a toolkit for diagnosis. So now that we understand what GRB is, how it happens, how it's diagnosed, the big question for many listeners is, what can I do about it? The good news, I gather, is there are effective treatments, right? Starting with lifestyle.
Absolutely. Lifestyle modifications are truly foundational. They're often the first line of attack. This includes crucial dietary changes, identifying and avoiding your specific triggers. Common ones are fatty foods, spicy foods, chocolate, caffeine, alcohol, citrus fruits, tomatoes.
Well, usual suspects.
Pretty much. Eating smaller, more frequent meals helps, rather than big, heavy ones. And really importantly, avoiding eating anything within, say, 2 to 3 hours before lying down or going to bed. Give your stomach time to empty.
What else?
If overweight or obese, weight loss can make a huge difference by reducing that abdominal pressure. For people troubled by nighttime reflux, elevating the head of the bed, not just propping up on pillows, but tilting the whole bed frame up 6 to 8 inches, uses gravity to help.
Right.
Avoiding tight clothing, belts, anything that squeezes your middle.
Oh.
And, a big one, quitting smoking. Smoking is known to weaken the LES.
Okay, those are all things people can start working on themselves. But what about medications? You mentioned the PPI trial. Are there others?
Yes, there's a range, depending on symptom severity and frequency. For just quick, occasional relief, you've got antacids, Tums, Melox, Melanta. They work fast by simply neutralizing the acid already there.
Like putting out a small fire.
Kinda, yeah. Then you have H2 receptor blockers, or H2RAs, like famotidine. They reduce acid production, but not as strongly as PPIs. They're good for milder or less frequent GERD.
Okay.
But for more significant symptoms, and especially for healing any damage like esophagitis, proton pump inhibitors, PPIs, omeprazole, pantoprazole, there are several or the most effective.
Yeah.
They really shut down acid production significantly, usually taken once a day, about 30, 60 minutes before the first meal.
Right, the heavy hitters.
They are. There are also prokinetic agents like metoclopramide. They help speed up stomach emptying and can tighten the LES a bit. But honestly, they're used less often now because of potential side effects. Some quite serious like tardive dyskinesia, those involuntary movements.
Okay, good to know.
And finally, alginate-based drugs like Gaviscon in some formulations. These work differently. They form a sort of foam raft that floats on top of the stomach contents, acting as a physical barrier to reflux.
Interesting mechanism. Foam raft, huh?
Yeah, pretty clever.
Okay, so lifestyle, various meds. What if those aren't enough? Or if someone has really severe GERD, or maybe doesn't want to be on medication long term, are there surgical options?
Yes, for sure. Surgical or procedural options are typically considered for severe cases that don't respond well to meds, or if there are significant complications, or sometimes just patient preference to avoid long-term pills. The most common surgery is fundoplication.
Fundoplication, what's that?
Usually done laparoscopically, meaning minimally invasive surgery. The surgeon wraps the upper part of the stomach, the fundus, around the lower end of the esophagus, essentially reinforcing the LES valve. There are different types like Nesson or Toupet, depending on how complete the wrap is.
So physically tightening things up.
Exactly. Another option, newer, is the LINX device. This is a small ring of magnetic beads placed laparoscopically around the outside of the LES. The magnets keep the valve closed to prevent reflux, but they separate to allow food to pass down when you swallow.
Magnets.
Yeah. And there are also less invasive endoscopic procedures done through a scope down the throat. Things like Stretta, which uses radiofrequency energy to kind of tighten the LES muscle tissue, or TIF, transoral incisionless fundoplication, which uses staples inserted via endoscope to create a partial wrap, sort of mimicking the surgery, but without external cuts.
Okay, lots of options there too. So for the long haul, what does managing GERD look like? Is it always about staying on meds? And how do you keep an eye out for those complications like Barrett's?
That's a key part of it. Once symptoms are well controlled, often with a PPI, doctors usually try what's called step-down therapy. The idea is to find the lowest effective dose or frequency of medication, maybe switching from a daily PPI to an H2 blocker, or just using meds on demand when symptoms flare up.
Trying to minimize medication if possible.
Exactly. But monitoring for complications is crucial, especially if someone has known Barrett's esophagus. That requires regular surveillance endoscopies, maybe every 3 to 5 years, depending on the findings, to check for any progression towards cancer. Early detection is key there.
Right.
And it's also important to discuss the potential long-term risks of PPIs, even though they're very effective. We know long-term use is associated with a slightly increased risk of things like osteoporosis, some vitamin deficiencies like B12, and maybe an increased risk of certain gut infections like C. difficile. So it's always a risk-benefit discussion with your doctor.
Yeah, that makes sense. Always weighing the pros and cons. Now, this makes me wonder, could symptoms that feel exactly like GERD actually be something else entirely? Because that would obviously need a different approach, right?
Absolutely. That's why the differential diagnosis is so important. Doctors have to consider other conditions that can mimic GERD symptoms, things like peptic ulcer disease or esophageal motility disorders. Problems with how the esophagus muscles work, like achalasia or diffuse esophageal spasm, gastritis, inflammation of the stomach lining itself, or even functional dyspepsia, which is basically indigestion symptoms without a clear structural cause, can sometimes feel like reflux.
Okay.
But what's really fascinating and honestly crucially important to remember is that GERD chest pain can sometimes feel identical to cardiac chest pain, like angina from heart problems.
Oh, wow. That's scary.
It is. So it is absolutely vital that if someone comes in with chest pain, cardiac causes are ruled out first and foremost. You don't want to miss a heart issue by just assuming it's reflux. Safety first.
That is a critical point. Wow. Okay, so when all said and done, after diagnosis and treatment, what's the general outlook for someone living with GERD?
The good news is that the vast majority of patients respond really well to treatment, usually a combination of those lifestyle changes and medications. They can achieve excellent symptom control and maintain a good quality of life.
That's reassuring.
It is. However, it's important to remember, GERD is often a chronic condition. It might require ongoing management. If it's not managed well, complications like Barrett's or strictures can develop over time, which underscores the need for sticking with the plan. And while surgery like fundoplication is generally effective, sometimes, way down the line, a reintervention might be needed. But overall, the outlook is generally positive with proper care.
Okay. Well, from understanding that malfunctioning valve, the LES, to recognizing those really surprising atypical symptoms that might have confused people for years, and exploring the whole spectrum of treatments, we've really peeled back the layers on GERD today. It's obviously a common condition, but as we've heard, its impact and how you manage it are, well, way more nuanced than just grabbing an antacid.
Absolutely. And knowledge is most valuable when you understand it and can apply it, right? Recognizing the signs, both typical and atypical, understanding what's going on underneath, and knowing when it's time to seek professional help. That's all crucial for managing it effectively and hopefully preventing those more serious long-term complications. Your body often gives clues. It's about learning to listen.
Yeah. And given how many different systems GERD can apparently affect, from your lungs way up to your teeth, totally separate from your stomach and esophagus, it really makes you wonder just how interconnected everything in our body truly is, doesn't it?
It really does.
It's kind of a powerful reminder that what seems like a localized issue can actually send ripples throughout your whole system in ways you might never expect. We hope you'll keep doing your own deep